Oh my God, what's going on? Is it happening again? All these respiratory illnesses all over the world. Crazy. Is this something new? No, it's not something new. We're gonna talk about that today here on Medicine Deconstructed. I'm your host, Dr. Jay Rutland. I mentioned two organisms circulating in China that you have not heard me talk about. These organisms are not just circulating in China, they're now popping up in Ohio and other parts of this country. No, I'm not freaking out. Because the first organism is known. It's called Mycoplasma pneumoniae. I see it all the time as a lung doctor. Mycoplasma is the smallest prokaryotic microbe in nature. There are actually 7 species of Mycoplasma that are pathogenic to humans. There's Urulicium, there's Genitalium, there's Fermentation, Penetrans, Pyrium, Hominis, and Pneumoniae. We're going to focus on Mycoplasma pneumoniae. This is the one that causes pathogenesis in humans in multiple ways. We mostly see it causing inflammation and pneumonia, but it binds to our respiratory epithelial cells, causing damage, and it can cause toxic damage by increasing reactive oxygen species in our cells and can also damage our immune cells. Due to the presence of this organism within our body, cytokines like interleukin-8, TNF-alpha, interleukin-1 beta begin to increase. And this leads to the immune cell recruitment to the lung, which worsens inflammation. There's also a toxin called CARDS, which stands for Community-Acquired Respiratory Distress Syndrome toxin, that causes evacuation and a ciliostasis of host cells. Remember, cilia beat back and forth to help the immune system. Ciliostasis means they're not doing that anymore. This also stimulates type 2 cytokines, which I've discussed before, and we should all remember what they are. In general, Mycoplasma pneumonia causes 10 to 40% of community-acquired pneumonia cases in adults and children. The most susceptible are children and young adults. That's why you're seeing it there. Patients are going to present with fever, cough, myalgias, and GI symptoms. 10% of patients can have neurologic symptoms and present with an encephalitis. You can also develop cold agglutinins to an eye antigen, which is located on red blood cells. This is going to lead to fatal hemolytic anemias and perhaps even thrombosis within those blood vessels. Sickle cell patients need to watch out. On chest radiography, chest x-ray, chest CT, you're going to see interstitial infiltration like this. You're going to see airspace consolidation like this. You're going to see reticular nodular findings. You're also going to see ground glass opacities and possibly some pleural effusions on CT. We've discussed these radiographic imaging findings before. They're not specific for Mycoplasma, so to diagnose it, it can be tough because you can't really see it on gram stain because Mycoplasma doesn't have a cell wall. We typically diagnose with cold agglutinin titers, but the gold standard are serologic diagnoses, right? You're going to see a 4-fold change in antibody titers over time, typically with an IgM antibody, which is going to rise earlier than the IgG. You do have to think about how common this is to help you diagnose and treat it. Treating it is really easy, but because there's no cell wall, we have to select therapies that inhibit bacterial ribosomes or inhibit bacterial DNA. So we typically are going to choose macrolides like azithromycin, Z-Pak, tetracyclines, doxycycline, and fluoroquinolones like levaquin for about 7 to 10 days. So no, I'm not worried. We know the organism and we know how to treat it. There also is another organism that's circulating, and this organism is common in kids and grown-ups. This organism is an adenovirus. Remember, viruses can have a genome that's either DNA or RNA. Adenovirus is a double-stranded non-enveloped DNA virus that causes infection in upper and lower respiratory tracts, along with GI tracts and the conjunctiva of your eye. It causes pink eye. 80% of adenovirus infections are in children under the age of 4. Adenovirus 3 is the most common serotype, but back to adenovirus. Infections can happen to adults or children in closed or crowded settings. Symptoms are going to be fever, pharyngitis, tonsillitis, cough, sore throat. In patients with a normal immune system, symptoms are going to abate within about 2 weeks. Pneumonia can occur in up to 20% of infants and newborns. That's 1 out of 5. Fatalities can happen too. In immunocompromised kids or adults, you can have dissemination, meaning the virus is all over the place. You can also have respiratory failure in 10 to 30%. Fatality rates in patients with pneumonia can exceed 50%. Adenovirus is detected by swabbing the mouth or the nose or performing more invasive procedures collecting tissue and performing either direct polymerase chain reaction or PCR or indirect immunofluorescence. There really isn't an antiviral therapy that's approved to treat adenovirus. However, cidofovir has the greatest activity. This is a cytosine nucleotide analog that inhibits DNA polymerase. It's given 5 milligrams per kilogram every 1 to 2 weeks or 1 milligram per kilogram twice weekly for however long the expert recommends. You can give cidofovir orally with a drug called brincidofovir. Bottom line is typically your immune system can take care of the virus, but if you're immunocompromised, like a lot of my patients, because I treat that autoimmune lung disease and knock out their immune system, you may need an antiviral to help. Remember, China was much more restricted during the pandemic, masking, social distancing, etc. These rules were just softened, which has likely led to all that is happening. I'm not worried about the rise of respiratory infections in China or really anywhere else in the United States because I understand the concern after collecting more information. I know that these are known organisms and we all know how to treat them. Relax. We'll see you next time on Medicine Deconstructed.